Coming up on this special Focus on Health, our team shares life-saving information about breast cancer. Chances are there's not a single person watching whose life hasn't been touched by this disease. For you, was it a mother, a wife, a friend? Statistics show 1 in 8 women will develop invasive breast cancer in her lifetime. In the next hour, we'll hear from medical professionals, but perhaps most importantly, profile women facing the diagnosis and sharing their own stories of hope and survival. Don't go anywhere. This Focus special report starts right now.
Focus showcases the people, places, and issues that matter to you.
Everybody has a story.
These are the stories that uplift and inspire right here in your neighborhood. Focus on what matters. You never know what you're going to see when you tune into Focus.
Support for Focus is provided by
the people of Air Products feel privileged to bring this programming to you. By supporting education and the arts, Air Products strives to improve the quality of life here in the Lehigh Valley, where we call home.
You're safe at home at Luther Crest, a Diacon senior living community in Allentown. Our mission is to offer premier accommodations and services so residents can cultivate a healthy and fulfilling retirement. At Luther Crest, we offer independent living apartments and cottages, personal care, skilled nursing, rehabilitative services, and more. Plus, the Luther Crest team strives to provide each person family-like support. You might say it's like a home run. Luther Crest.
News doesn't stop. We cover it 24/7, 365, because that's what our readers demand from us. You need to know what's going on, who's playing by the rules, or who's breaking them, who's winning and who's losing. The full range of the human experience plays out every day in the pages of our newspaper and website. The platform you choose to engage with us is your business. Delivering the news is ours.
Thank you for joining us for this special Focus on Health. I'm Laura McHugh. Next to skin cancers, breast cancer ranks as the most common cancer among women in the United States, according to the American Cancer Society. This year alone, more than 200,000 women will get their diagnoses, and about 40,000 women will die from it. But as we are about to find out, more and more women refuse to stand by and wait for a diagnosis. About 5 to 10% of breast cancer cases are thought to be hereditary, and a growing number of women now take their future into their own hands. Focus reporter Brittany Garzillo tells us more about the preventative medical procedures they undergo. Brittany?
Thanks, Laura. You may have heard about it in the news recently from Hollywood celebrity Angelina Jolie. It's called a prophylactic mastectomy, and it's drastically changing the lives of those who are genetically predisposed for breast cancer. It's a surgical procedure removing one or both breasts to reduce the risk of developing cancer later in life. Doctors say it's become a popular preventative option within the last decade and can reduce the risk of breast cancer by about 90%. One courageous woman in the Lehigh Valley adds her name to the list of cancer previvors by undergoing a prophylactic double mastectomy. Take a look.
That's from when we were little. That's hilarious.
In her serene mountainside house in Regalsville, Kelly Vanek and her 2 sisters take a stroll down memory lane.
That's Amy and Brandy and me and Marcy.
It's an afternoon full of family, good food, and fond memories.
Joanna and
Look.
Mm-hmm. But behind their sincere smiles is a family history that isn't quite as pleasant.
Well, you wonder if she had the gene, too.
Yeah.
3 of Kelly's 4 sisters were diagnosed with breast cancer, and in 2008, her mother passed away from it.
When you have 3 sisters and a mother who've had breast cancer, you just kind of figure that, you know, the shoe's going to drop someday.
Unfortunately for Kelly, that shoe fit. After consulting with a genetics counselor, it was revealed that Kelly inherited the BRCA1, or BRCA1 gene, and was likely to become the 4th sister in the family to face a grueling road ahead, living life with breast cancer.
Once I got the positive test, I'm like, well, what should I do?
I don't think we were surprised because 3 of us had already been diagnosed. I think the biggest surprise was that Kelly was positive.
Hiking, biking, whitewater rafting. Kelly's active lifestyle doesn't leave room for the chaos of breast cancer. She immediately headed to genetics counselor Andrea Smith of St. Luke's Cancer Center to discuss her options.
I work with individuals who are at high risk to develop cancer or who may have cancer to help determine whether or not there might be a hereditary element to the family.
According to Andrea, the BRCA gene accounts for about 10% of all breast cancers. She says individuals like Kelly are at high risk to carry the gene mutation when he or she has a personal or family history of breast cancers, especially those diagnosed under 50. Multiple relatives with breast cancer, ovarian cancer, or bilateral cancers, or individuals with Ashkenazi Jewish ancestry.
If I understood then what I understand now about the information from the genetic testing could help me make choices that could prevent a breast cancer diagnosis, I would have taken action then.
I decided to try to be proactive.
After consulting with surgical oncologist Dr. Lee Riley at St. Luke's Cancer Center, Kelly weighed her options, taking an anti-hormone pill, increasing her screenings, or opting for a new preventative surgical procedure, a prophylactic mastectomy.
A prophylactic mastectomy is simply removing both breasts. And prophylactic means you don't have cancer yet, so you're trying to prevent it. Those women can either undergo no reconstruction, or they can undergo various types of reconstruction.
Kelly made the courageous decision to undergo a prophylactic double mastectomy and immediate breast reconstruction. It reduces her 87% chance of developing breast cancer to less than 1% and leaves her body with no visible changes.
I didn't say like, oh, I had a prophylactic double mastectomy. Nobody would know.
The BRCA genes were really only discovered within about the last 15 years. So it has opened up that possibility of identifying these women who are at high risk before they develop cancer.
Kelly's decision mirrors that of Hollywood actress Angelina Jolie, who recently went public about her decision to help prevent cancer before it begins.
I think if she had been that person speaking 3 or 4 years ago when I was first, being advised to have genetic testing, I would have perked up and listened, and maybe I would have done the same thing and avoided the breast cancer diagnosis that I eventually received.
Despite Kelly's success with the procedure, Dr. Riley says a prophylactic mastectomy is not for everyone.
And if they're tested for the gene and they're positive or they have a mutation, those are the women that I think the prophylactic mastectomy is a reasonable option.
I think cancer changes your life. You realize what's important. Your priorities change. You don't sweat the small stuff anymore. And I think with Kelly, she's a great example of that. She really goes full force with life.
For Focus, I'm Brittany Garzillo reporting.
Thank you, Brittany. Our next guest, Natalie Blumberg, understands these decisions all too well. Earlier this year, Natalie tested positive for the BRCA or BRCA gene. Since then, she started to chronicle her experience in a blog at nataliesjournal.com. Natalie, welcome and thank you for being here.
Hi, thank you for having me.
Natalie, why did you decide to get tested in the first place?
I had experienced some abnormal bleeding, and it wasn't a major concern, but I was due for a doctor's appointment, which is something I hadn't been good with most of my life, taking care of the physical aspects of my life. I stumbled upon Dr. Taylor from St. Luke's Hospital and had read some recommendations that he was, a great doctor, and I had also known someone that went to him and had a positive experience. So I made an appointment, went to see Dr. Taylor, and while I was there, he asked me some questions that I hadn't really thought about before as far as my family history, which does include cancer on both sides. So he had thought with the abnormal bleeding and some of the things that we had found on my ovaries, it would be a good idea for me to take the BRCA test, which I had been somewhat familiar with because of Angelina Jolie and her story and what she had experienced. So I went ahead, found out my insurance covered it, went ahead and took the test.
What did your results find? What did you find out with your results?
Well, I really, even with my family history, I wasn't too concerned. I've lived most of my life in denial and not thinking of my health necessarily. And so I was really surprised when the results came back that I had an 87% chance of developing breast cancer. And also a 50% chance of developing ovarian cancer.
50%, that's like flipping a coin, and 87%, that's, as close to 100% as you ever want to hear.
That's right.
What was the next step at that point?
Upon hearing that, everyone was really surprised with how quickly I reacted to the news and started, a game plan. And that was to stay cancer-free and to go about that with the help of my doctors and researching my different options for myself. The one thing that I stress and I've learned through this experience is educating yourself, being your own patient advocate, not going into this blindly. So I decided for myself, this was a personal decision, to go ahead and get a total hysterectomy, which would lower my chances, and a double mastectomy, which would lower my chances to 5% of getting breast cancer. So for me, it was a no-brainer. I knew there were other options, but for me, my decision was to go ahead and to do the surgery.
How long did you grapple with that decision, or was it an instinct for you?
It was an instinct for me. I have a daughter. I'm a single mom. I'm her only parent. And so for me, I went into mom mode and survival mode and knew that I had to be here for her and to take care of her. So knowing that this would be the best option as far as lowering my risks, it was an instant decision.
You brought up your daughter. In one of your blog posts called Knowledge is Power, you talk about the guilt you feel in potentially passing this along to your daughter, which I imagine is a very common feeling among a lot of women who find out that they have this genetic mutation as well. How are you dealing with that part of it?
That's a really good question, and yes, I do talk about it in my blog. I have found that through this experience, that's probably the most difficult thing for me to deal with, is the guilt I feel knowing that I have passed this on to my daughter. Now, I am not sure of, the percent, chance that she has of getting this. I do know it could be in her future. So one of the things that I focus on now is not just changing the future of my health and the outcome of the situation, but focusing on the outcome of my daughter's health, doing the things that could keep her from hearing that she has this dreaded disease.
Has she considered whether or not she's going to get tested yet?
She has been my biggest supporter. She is right behind me and supports me getting the test, supports me getting the surgeries, and she has said that if, when the time comes for her, which will probably be in her early 20s, that she'll take the test too. And she knows that eating right and exercising will help the outcome of that test.
Because she's how old now?
She's 12.
So an age that she's going through a lot of changes herself.
Right. And I think this is a difficult situation. It's not as difficult as it could be for someone who actually has a cancer diagnosis, but it is difficult. It's inconvenient, but she's getting to see me and how I handle this, which is why I'm making sure that I educate myself and share this information with her and other women.
Well, Natalie, one of the first things I said to you when I saw you this morning, you said, "Oh, your hair looks so beautiful. You've changed it." And you...
I have changed it. Through having the total hysterectomy, there are some side effects, and they're due to the hormone levels that change. And one of the things that I've experienced is extreme hair loss. So I opted to go and get myself some new hair, which I'm wearing today. And I feel lucky that that's my only worry at this point.
And so at this point, you've had your hysterectomy. You had that in
yes,
September, correct?
I did. Mm-hmm.
And what's the next step then?
I see my plastic surgeon through St. Luke's Hospital, Dr. Morrissey, on Wednesday, this coming Wednesday, October 2nd. We're going to discuss my options as far as reconstruction, what is available to me, what he recommends at this point. So I look forward to that, and then I will be sharing that with my readers as well.
And we can continue to follow your journey at nataliesjournal.com?
Yes, I will be honest in my journal, sharing the different aspects of this and the progression.
And why did you decide to make it public, this journey of yours?
I decided this probably as quickly as I did my decision to go ahead with the surgeries. I felt that the Angelina Jolie situation was wonderful because she put this out there. However, I thought I'd take it a step further and show everyone not only that the test is available and what she looked like afterwards, but step by step how this affects you. the decisions that have to be made, the choices that you have. So I just felt it was a chain of responsibility that I had to follow.
Thank you so much for sharing this information, Natalie,
Thank
and for
you.
sharing it not only on air with us, but online in your blog.
Thank you.
For women who either don't have any known risk factors or can't control the ones they have, the American Cancer Society recommends annual mammograms starting at age 40. Its reports show that cancers found during these screenings are not only smaller, but have less likely spread to other parts of the body. Focus reporter Grover Silcox joins us to share the newest screening technology available in our region. Grover?
The old saying, an ounce of prevention is worth a pound of cure, applies big time to breast cancer. When a woman develops breast awareness to detect lumps or tumors or any changes early on, she goes a long way in preventing and even beating breast cancer. I spoke with a radiologist and a cancer survivor at Lehigh Valley Health Network about the most effective techniques in diagnosing breast cancer, from self-examination to advanced imaging systems. And here's what they had to say.
Legions of women battle breast cancer each year. They celebrate their victories and pay homage to those who fought the good fight. But as they champion their cause, they know that early detection through a screening mammogram is one of their greatest weapons.
The screening mammogram saved my life.
In June of 2012, Joan Edwards, a 59-year-old, learned she had breast cancer after going for her annual screening at Lehigh Valley Hospital's Cancer Center.
Actually, it was from a screening mammogram. I would never have detected it on my own.
A mammogram's a two-dimensional X-ray of the breast, which can detect masses and other abnormalities. The American Cancer Society recommends that women over 40 get one each year.
But the screening mammogram picked it up, and then the doctors called me back. And we went through, ultrasound, biopsy, and then it was positive.
Dr. Priya Serene, a breast imager at the center, served on the medical team that diagnosed and treated Joan's cancer.
In her case, she came in, it was a very small area of calcifications and mass, and it would have taken time for her to actually feel a lump.
My tumor was so small that only way to detect it was a screening mammogram.
The problem is by the time a patient can typically feel something, which is generally, they say, about a centimeter, it's already bigger. Sometimes if they don't feel it until 2, then you worry more about it spreading to the lymph nodes.
Joan was diagnosed with cancer in her right breast. But because of early detection, her prognosis was good.
It was diagnosed at a very early stage, meaning the actual abnormality was very small, allowing her to have breast conservation.
She underwent surgery and chemotherapy, and now her cancer's in remission.
Just to kind of give you a better sense of what that means.
Although mammography saves millions of lives, it does have limitations. It can miss some cancers, especially in women with thicker breast tissue. But science has developed a new system called tomosynthesis, which takes 3D images.
It takes multiple images through the breast and allows us to really see through the denser portions of breast tissue and get a better sense of whether or not there's a true abnormality representing change from prior studies, or whether or not it's just a benign process or just normal tissue.
Tomosynthesis generates about twice the radiation as a conventional mammogram, but still within FDA guidelines.
It's actually taking different levels of a breast. It's actually, it's kind of like a CAT scan.
Using 3D imaging, the center has been able to rule out cancer in certain patients who might otherwise have come back for further tests.
Right now, it's not reimbursed by insurance companies. That might change in the future.
Meantime, Dr. Serene encourages women to be aware of their breasts, notice any changes, and schedule regular checkups and yearly mammograms, even when it seems inconvenient.
I can't stress it enough. Screening mammography is the only diagnostic test that's been proven to save lives.
Don't be afraid of being tested. It's your fear that's going to, hurt you more so than everything they can do to help you.
Take it from Joan Edwards, one of millions of Americans who battled cancer and won. For Focus, I'm Grover Silcox reporting.
To continue this discussion about 3D mammography, Easton Hospital breast surgeon Dr. Laura Borges joins me now. Thank you so much for joining us, Dr. Borges.
Thank you for having me.
So when we talk about 3D mammography, how is it different from typical mammography?
So the brief history of mammography is it started out as analog, which is regular film mammography, and then it progressed to digital, which is now the standard of care. But now we have the newest technology, which is 3D mammography, or what we refer to as tomosynthesis. And what it is there are multiple pictures, about 15 pictures taken for each image of the breast, and a computer assimilates all of these into one big image, and it poses a 3D image for the radiologist to read. The benefit of 3D mammography over digital or analog is that you get a much clearer, more distinct and defined picture of the breast tissue. So it enables us to find smaller tumors at a very earlier stage, at a much earlier stage, which is obviously what we want in a screening test.
So what are the benefits of getting that early diagnosis, of getting that screening early?
So obviously the sooner we catch it, the less treatment that might be required, the less chance of it spreading to other areas of the body, and it makes it a lot easier to treat for the patient as well as us, obviously.
Now, who's going to be a good candidate for 3D mammography versus standard mammography?
So really anybody can benefit from the 3D mammography technology. However, the people who benefit the most are people or women with dense breast tissue, and that tends to be the younger patients, usually people under the age of 50. But you can have an older woman who has dense breast tissue who will still benefit from this technology. And then obviously breast cancer survivors, we like to use the technology on them because since they've developed the disease initially, they're at risk for developing a recurrence.
And how often should they be having those screenings if they are a breast cancer survivor?
So screening is really across the board, starts at age 40 and is every year thereafter. Even for breast cancer survivors. Once they get through their first year of treatment, they go back to the regular screening pool like everybody else, and it's annual.
And so we hear a lot of actually different recommendations about how often people should be screened, but you're saying starting at age 40 on an annual basis.
Right. So the United States Preventative Task Force came out several years ago and posed new screening recommendations, but really nobody has really adopted those. The recommendations were not to start till the age of 50 and to go every other year. And the American Cancer Society and pretty much the medical profession does not feel comfortable with those recommendations. There are a significant number of women under the age of 50 who are diagnosed with breast cancer, and if we adopted those screening guidelines, we would be missing all of those cancers.
And aren't some women even recommended to start before age 50 if they have certain risk factors?
Yes. So if you have a significant family history, and what does that mean? It means primary or first-degree relatives, so that's a mom or a sister who had breast cancer at an early age, and for us, the definition of early-stage breast cancer is under the age of 50, then you need to start your screening 10 years before that. So if your mom had breast cancer at the age of 43, you need to start your screening at the age of 33.
Wow. And what other risk factors should women be aware of as they're looking for, considering starting earlier? What are the other risk factors? If
you have typically fibrocystic breasts, so that's very lumpy breasts, and that's a normal variant, but sometimes that goes along with having dense breast tissue, and sometimes it's difficult to monitor or evaluate. So you might opt to have ultrasound earlier as an adjunct to your screening mammogram.
And so, in general, when cancers are found early, what are the survival rates for the different stages of breast cancer?
The survival rates are extremely high. I mean, they're approach 100% with very, very early stage breast cancer. This is not the death sentence that people thought of, 20, 30, 40 years ago. Therapy and prognostic factors have changed dramatically, and we can really treat and cure a lot of breast cancer at this time.
So as a breast surgeon, how does this aid you in your ability to get in there and remove these cancers earlier, having these earlier screenings and better screening technologies available?
So it's great for me because I get to offer the patients breast conservation therapy, or what most people can call it lumpectomy instead of mastectomy. So obviously people are happier when they are able to save their breast, and so that enables me to offer that to more people.
And so where would that line be? What stage or how large of a tumor do you decide and make those calls?
There's not a hard and fast rule. It depends on the size of the tumor, but also the size of the breast. If you have a very large tumor and a very small breast, then lumpectomy is probably not going to be a great option. But if you have a very large breast, then that can accommodate or tolerate a bigger resection and still enable the patient to have breast conservation therapy.
And Dr. Borges, how long have you been practicing?
I finished my training in 2002.
So for more than 10 years, and where does this rank on the list of new technologies that are really changing the landscape?
Yeah, the Cleveland Clinic came out with a list of the greatest technologies in the past year for the year of 2012, and this is on the list. I believe it was number 9. So it's a pretty big deal.
And how widespread is the use of it at this point?
It's not standard of care yet, so insurance companies mostly are not covering the full cost of the 3D mammo. Blue Cross Blue Shield, I believe, just approved covering that cost on September 9th of this year, and I'm confident that the other insurance companies will soon follow. However, each facility has come up with a small additional fee for the patient, out of pocket for the patient. Easton Hospital is currently charging $45. And other institutions might charge $50 or $60. So I think that's, if you're not really strapped, I think $45 is not a big cost to, have better peace of mind.
Dr. Borges, thank you so much for being here and sharing this information with our viewers. Really appreciate it. Now, if you're just joining us for this Focus Special Report, we're covering all the bases on breast cancer. We've learned about the latest screening technology in our region, and now Brittany Garzillo joins us to explain one of the newest treatments available. Brittany.
A new treatment called intraoperative radiation therapy, offered at St. Luke's University Health Network, may save some women weeks of radiation after surgery. Dr. Lee Riley joins me now to explain. Dr. Riley is St. Luke's Section Chief of Surgical Oncology. Thanks so much for being here with us today.
Thanks for having me, Brittany.
You're welcome. So it's called intraoperative radiation therapy, or IORT for short.
Correct.
Tell us about it.
Yeah. Well, it's typically what we do is treat women for 6 weeks after they have breast cancer if they're having a lumpectomy. And now, instead of that option for some women who have early breast cancer, we have a device in the operating room where we take the lump out and we put this plastic ball in there, shoot a little radiation through that ball that irradiates the area around where the tumor was, take the ball out so there's no radiation left, close up the incision, and they go home.
Oh, my goodness.
So it adds about 20 to 45 minutes to the operating room time, as opposed to 6 weeks of, weekly treatments or daily treatments Monday through Friday for 6 weeks.
So what kind of women are candidates for this treatment?
Well, they did a study over the last 7 years where they took women, flipped a coin, and half of them got 6 weeks of radiation therapy and half of them got the 1 day. And you could be as young as 45. You had to have relatively early cancer, so smaller, about an inch is probably sort of an average size, and it had to have favorable features, so we didn't think it was a really aggressive cancer. And that's a pretty common cancer type. As we do this at St. Luke's, we're starting out a little bit more safe, so we've got pretty conservative criteria, though nothing's really set in stone. We'd like it not to be in the lymph nodes. And smaller tumors, and women usually over the age of 60, 65, 70, in that range. If you look around the country, everybody's doing it relatively different. So California, they'll treat women who are 45. So it's just where their comfort zone is.
So the best thing to do is for these women to consult with their physicians first to determine whether or not they're a candidate.
Exactly. And everybody have different kinds of needs and criteria, and there's so many factors in the tumor. It really is sort of an individual thing.
Now, how does this therapy compare with the typical course of surgery plus radiation?
Typically, you would go through surgery. You'd go home that day if you're doing a lumpectomy. We'd check a lymph node. You'd heal over the next 2 to 3 weeks. Usually people are back to work in a week, but we'd like the wound to heal really pretty well before we start radiating it. So typically no sooner than 3 weeks we would start radiation therapy, where they would come into the radiation facility, lay down on a table. They would get a couple of tattoos that are very, very tiny that you can't really see, but that way they can come in the next day, and it's sort of like going to a tanning salon, it only takes about a minute to get the treatment for when you're getting your daily dose. But then you have to do that Monday through Friday for 6 weeks. And that's a big inconvenience. The breast starts to turn red after about 2 weeks. Most women don't blister, but some can. And then after about 2 weeks after you're finished, the redness goes away. But it's a lot to go through. It's 6 weeks of treatment.
Now, has it been tested long enough to understand the long-term effects and the survival rates?
Well, Depends, because for any treatment, like for when we started doing the lumpectomy with the radiation therapy, we released results after 5 years and said, all right, it looks like it's not coming back. And so we adopted that technology. And so that's when we started doing lumpectomy and radiation therapy. Then 10 years later, we do another study and see how those women are doing. And then 15 years, we do another study. So typically, we adopt things sort of at a 5-year interval. And we're just reaching that result now. When the paper first came out, they had people out to 4 years, but they had other people that have been on for a longer time. So we're in that ballpark with this. And the recurrence rate when they published the paper, whether you had mastectomy, or not mastectomy, lumpectomy with the standard radiation or the IRT, was about 1% in each group. They were statistically identical. But we'll continue to follow that group out for many, many years.
How is this changing the lives of cancer patients?
It's dramatic. I mean, it's funny because the people who go through it now don't really know what they're missing, and I tried to tell my patients when they're coming in, because they were still getting the 6 weeks, we didn't have it, and we'd talk to them and I'd say, there's going to be a new technology out here. It's not available, or you're not a candidate, but if you hear about it, I wish we had it sooner, but we don't. But they're so grateful for the women that are coming, after them, that things are changing. And I think it makes the whole field encouraged that we are making really pretty neat strides.
Now, do you foresee using this kind of treatment to treat other cancers besides just breast cancer in the future?
I do. And at organizations like Fox Chase or MD Anderson or Memorial Sloan Kettering, they've been using radiation therapy in the operating room. They actually have the whole linear accelerators at some of these places built in. So they've been trying to see, can you treat the pancreas, or can you treat lung or the rectum? This just makes that kind of technology a little bit easier and more portable, so that you don't have to have a $3 million machine inside an operating room. And so, yes, I do see it. There are studies that have already come out with this device, looking at rectal cancer and other things. Wow. So it's coming, yes.
Now, I know that in fewer than 50 sites in the United States actually offer this technology. So this is something really rare to the Lehigh Valley and to St. Luke's. It
is. I think it's the only one for the intrabeam. I think it's the only one in Pennsylvania. I don't think there's one in New Jersey yet. I'm going to New York tomorrow to look at an area where they're doing it a lot. They've been doing it. And I see it coming. There are 50 sites is not, it's not like we're the first kids on the block. But it's out there, and I do see it coming.
The world of technology, just absolutely amazing. Dr. Lee Riley from St. Luke's, thank you so much.
No, thank you, Brittany.
Laura?
Well, according to our next guest, finding the right treatments for the right person now leads to a greater number of survivors than ever. From Lehigh Valley Health Network, please welcome hematologist-oncologist Dr. Catherine Harris and radiation oncologist Dr. Jeanette Plouffe. Thank you so much for being here today. What do you mean when you say finding the right treatment for the right person?
There are lots of new studies coming out to suggest that the parameters we used to use to decide what treatments were appropriate for patients are really not the be-all and end-all. There's a lot more that we can learn about tumors to see if they're going to be sensitive to our treatments and if our treatments are indeed going to have sufficient impact on their survival.
How is this different from what's always been done?
Well, we always used to think of breast cancer as one disease, but it's become very clear that there are multiple types of breast cancers. And certainly every patient is unique, every tumor is unique. So we're trying to tease apart the important factors that drive a particular cancer and target our treatments to those things.
So how do you identify the right treatment for the right person?
Well, it's a multi-step process, meeting the patient and trying to determine what their goals are, what they intend to get out of the treatment that they're receiving. And then looking into, again, the specific factors of their disease. The basic principles are following things like stage, how far along the tumor is, as to what their outcome may be. But then there are more sensitive factors, like Dr. Harris alluded to, the actual biology of the tumor that help to guide what treatments are going to be most beneficial.
Is there any kind of, guidance that you use typically when you're deciding between what I typically think of the standard courses of treatment, surgery, chemo, and radiation? Are those still the first of all, are those still the treatments that are the most common treatments?
Very much so. Typically it's a combination of all three. As we talk about with our patients, surgery is most often in the setting of breast cancer the first step, both to remove the tumor as well as to give us an accurate stage to guide what treatments then should follow. Systemic therapy, such as Dr. Harris delivers, deals with both the local effects of cancer as well as systemic, or keeping it from spreading. And then radiation treatments are primarily geared towards local control, keeping the cancer from coming back in the original site. But there's also survival benefit from radiation. But typically all three are employed.
What's systemic treatments?
In breast cancer, the two major kinds of treatments are chemotherapy and hormonal therapy, or anti-estrogen therapy, since many breast cancers are hormonally driven. So to really determine what's best for a particular patient, again, as Dr. Blouth said, having an accurate staging is very important. It used to be that years ago we were much more likely to give chemotherapy to more women. But as we followed patients along for many years, it's clear that over the long term, there can be some unexpected long-term consequences of chemotherapies, such as cardiac disease, secondary cancers, and other, very life-threatening illnesses. So we've been trying to figure out who really needs aggressive treatment and who really doesn't need those sorts of treatments, so that they are not subjected to those short and long-term side effects of the treatments.
So if somebody's found early stage, since you're saying staging is a key factor in identifying the treatment, what is a typical treatment versus somebody who's found at a more advanced stage, stage 4?
We're big proponents of breast conservation when the patient appears to be an appropriate candidate for that, and that means being able to, save the breast and treat it for the equivalent outcome as to what used to be recommended, a mastectomy. So for early stage of disease, it will typically involve, partial breast surgery, followed by some form of systemic or drug therapy, and radiation treatments to treat the remaining breast tissue to prevent recurrence within the breast and or lymph nodes. And that's where most of the changes in radiation have come about, is different schemes trying to shorten the overall course of radiation so that it's less cumbersome or frustrating for patients, a little bit more convenient, fitting with their lifestyle as well as, again, their goals. So that's one of the changes that's really taking place in our field, is trying to come up with the regimens that aren't quite as detrimental to quality of life, and also, reducing the long-term risks of radiation therapy.
So at what stage typically now is mastectomy considered or looked at?
There are really a couple of indications that a mastectomy is needed. For a patient who may not have an acceptable cosmetic outcome with a breast-conserving surgery, so somebody who has a very large tumor in a small breast, mastectomy is certainly one consideration. If someone is desirous of maintaining the breast, keeping the breast, then sometimes we will give chemotherapy or hormonal therapy prior to surgery to shrink the tumor and allow for a better cosmetic outcome. So that's sort of not an absolute indicator that a mastectomy is needed, but it would certainly be a consideration. Times when mastectomy is really preferred is when there is tumor that's involving, we divide the breast up into sort of a clock face and talk about kind of quadrants. And if there's tumor that's sort of over multiple quadrants, then really breast-conserving surgery is not a safe surgery. And obviously our primary goal is taking the best care of the patient. So a mastectomy is really preferred in that situation due to safety reasons.
What percentage of breast cancer cases are resulting in mastectomy nowadays?
That's a difficult question. There are lots more mastectomies being performed, not necessarily because they are medically indicated, but because of something that we term cancer phobia. There's a lot more media attention on breast cancer and breast cancer risk. So sometimes younger women who are diagnosed with breast cancer, even if they're a candidate for keeping the breast, they may opt to have a mastectomy for fear of having to deal with a recurrence or a second breast cancer later in life. There's also a lot more options nowadays for reconstruction, which makes mastectomy a little bit more of a reasonable option for women. So again, it's kind of a multi-part answer. Not that we're seeing more advanced cancers, but there has been a trend toward more aggressive surgery for those reasons.
And finally, the takeaway from all this is, how is it affecting survival rates, being able to tailor treatment so specifically now?
Breast cancer is really one of those diseases where we've made a lot of progress, both in terms of curing more patients. We've identified some particularly aggressive subtypes, developed targeted therapies that kind of neutralize sort of the proteins that are involved in causing the aggressive nature of the cancer. And our treatments, on average, can reduce the risk of a reoccurrence. When we talk about reoccurrence, we're really talking about the development of advanced metastatic disease by about 50%, compared to somebody who receives no treatment to reduce that risk. So the other really nice thing is that we are being more mindful of our survivors and paying attention to their long-term quality of life. So being better able to identify who needs aggressive treatment and who doesn't, we're also finding that patients are living better quality of life when they are surviving breast cancer.
Well, Dr. Harris, Dr. Blau, thank you so much for being with us today. In the United States, more than 2.8 million women can proudly call themselves breast cancer survivors. But the effects of cancer don't just go away after they hear the joyful news that they are officially cancer-free. The surgeries and therapies that followed often leave their bodies and lives changed forever. I met one local woman who years later still battles a condition that affects many breast cancer survivors.
More than 5 years after Joan Anastasi officially beat breast cancer, she finds herself back in the hospital.
Hi, Joan. Come on in.
To treat the lasting effects of her cancer surgery and treatment.
This arm obviously is very small, and this arm has ballooned up. The shooting pain. Once in a while I'll get a shooting pain at my arm like this.
Uncomfortable swelling accompanies that shooting pain in Joan's left arm.
The swelling just felt like it was bursting. Felt like something was bursting out of my hand.
Joan describes the symptoms of lymphedema, a common condition for many breast cancer survivors who have had one or more lymph nodes removed during a mastectomy or lumpectomy.
Lymphedema is one thing that is unpreventable when you have breast cancer. I started getting lymphedema from the beginning, and my arm would swell, but the swelling would go down on its own.
Without lymph nodes to drain and carry fluid away from her extremities, Joan recently turned to therapy.
Realistically, therapy is the only thing that will help. So the fingers still look pretty good.
So 2 to 3 times a week, Joan comes to Easton Hospital, where she spends about an hour with Kara Wales, a certified lymphedema therapist from Good Shepherd Rehabilitation. She says they're most concerned about preventing a serious infection such as cellulitis.
You and I, if we have a hangnail or we get a bee sting or a sunburn, we really don't pay much attention to it. It's not a big deal. But for someone that has a disruption to their lymphatic system, as in lymphedema, it can, not always, but it can cause a raging infection.
At Good Shepherd, Kara follows a routine called complete decongestive therapy. She begins by carefully measuring each of Joan's fingers and specific positions on her affected arm.
And it's always the same spot so that everything's consistent.
Then Kara moves on to manual lymphatic drainage.
It's a massage done in a very specific pattern along the lymph channels, and it's to move the fluid back up the arm into other areas of the body that can absorb that extra fluid and filter it so that it can go back into the regular vasculature.
Finally, Kara wraps each of Joan's fingers and her entire arm in bandages, a detailed routine Joan continues at home in between her appointments.
So part of what makes the bandages work is that there's a normal muscle action pump in the arm that the more they use it, the more the muscle pushes against the bandages and can help move that fluid back up. These are, again, just breaking in the bandage a little bit.
After she completes therapy, Joan will be fitted for a special compression sleeve, which she'll have to wear regularly. It's one of the ways cancer may have changed her body, but deep down, Joan says, she's still the same person as always.
To continue the conversation about life after cancer, Easton Hospital's Marianne Callie joins me now. Marianne is the Director of Oncology Services there. Marianne, thanks for being with us today.
Thank you for having me.
For a lot of breast cancer patients, they go through treatment, whatever that is, surgery, chemo, radiation. What is the next step after they're discharged and hear the great news that they're cancer-free?
That's been a journey for them. For some patients, it could be
a year, several years. If they're on hormone therapy, it could be up to 5 years, and then they're considered cancer-free. But from the day they're diagnosed, they're considered a survivor. So we like to look at all of that as like you made it and you're doing great through that whole treatment process. But when they finally have been discharged from their medical oncologist, their surgical oncologist, they get scared. They're almost to the point that they're not sure, how can I do this without always having that follow-up appointment and just seeing their general practitioner. So we see that they get a little nervous about that because they like that checkup because they always have that fear of it might come back. And so we see patients, we try to, with our breast care nurse navigator and with the nurses that they've made contact with, that we can keep them feeling healthy and doing the right thing when they go through that piece that they're separated then from their oncologist. And I think that that's the time that they start to learn how to know that everything's going to be okay and they don't have to keep that thought always in the back of their mind.
So how often do they need to see their oncologist typically at that point? And is it the oncologist that they're actually seeing?
Yes. Most do want to continue to see their patients, and it's usually yearly then after that time that they will go back to just do that follow-up. And that usually is who's going to take care of providing them with having their mammograms done on that year basis, and or more frequently if something has arisen that they need to have taken care of.
And physically and biologically, for a lot of women who have experienced breast cancer, their bodies are changed often forever. We saw it in the case of lymphedema. This is a very common issue. What are some other ways that their bodies biologically are just changed forever?
Mm-hmm. Some, it could be if they've gone through chemotherapy with their hair. They may have lost their hair, so it has grown back, and it might be a whole different color or a whole different texture. Mm-hmm. They might have had straight hair, now it's come back and it's curly. So they see that as a body image change. Depending on what surgery they've had done, again, that could be a life-changing experience for them if they've had to have mastectomy and or reconstruction. So again, that's something that has occurred to them that they now have to forge forward with, as what those changes have brought them. But they always have to remember that they're a survivor and they've gone through this, so they will adapt to those type of changes that occur. Some may have gained weight because of hormone therapy that they've been on. So they now have to learn how to do different type of exercising or a way of eating that will be different than what they did prior to maybe being diagnosed with having cancer.
It also changes them from the inside out, too. It changes your life forever once you've borne that.
Yes.
Once you're a survivor.
Correct.
You're
And we see that a lot, and I think they already have a whole different outlook on life when they're doing that because they want to live for the moment. I see many patients do things that they probably would have never have done if indeed maybe they hadn't been diagnosed, and that's actually rewarding to a lot of patients and to their families because they take on a whole different aspect of life and go skydiving that they probably would have never have done that, or something as daring as something like that, or how they want to give back. I have volunteers that were that are breast cancer survivors, and that was their way of giving back because so many gave to them. So they have come back and work in our center as being volunteers. So again, they see that as an opportunity and a change that they probably wouldn't have done.
A lot of times we hear a lot about 5-year survival rates. Is that 5-year mark a really important milestone for a lot of women?
I think that continues to be, but as I said to you before, we really look at it from the day they're diagnosed that they're considered a survivor. But we see a lot of treatment planning, and if they have to be on hormones, they may have to have been on it for 5 years. So they do look at that as, and I know, statistically we look at 5-year survival marks. And so it truly is a number that seems to have stuck that we continue to use as a marker.
So as Easton Hospital's Director of Oncology Services, what piece of advice do you have for somebody who's gotten the great news that they're cancer-free and they're being discharged? What advice do you have for starting life after cancer?
just live the life the best you can, I think, and just go for it, because there's no reason you shouldn't be able to enjoy and continue on and do everything you want to do and more. I mean, I just think that you're blessed and you really need to move forward and don't look back. Just keep going forward. And I think, and give to others. And I think that sharing and being able to be with others is like the most fun that you can do.
Marianne, thank you so much for being with us today.
Okay, thank you.
Finally, this past weekend, thousands of women and families came together for the Women's 5K Classic. This Lehigh Valley tradition started way back in 1993 with just 250 runners and walkers. 20 years later, the race attracts 5,000 women and raises more than $250,000 for programs such as support groups and screenings for low-income women. Focus team members Maggie Boyer and Michael Lloyd bring us the sights and sounds from this emotional event.
We started actually 21 years ago, and it was started really to get women into fitness because women who exercise, there's a lot of studies that they stand a greatly reduced risk of developing breast cancer. But then when we did the event in October, we decided to link it with breast cancer because we thought people would be much more motivated to give money and support our event if we also had a cause.
The best part of this event is that it's all about stories. Stories about coming back year after year after year, meeting together in a special place in the Lehigh Parkway.
I knew that was pain that I should not be feeling.
Well, my sister had breast cancer, and she was only 27. And so about 20 years later, I had ovarian cancer. So we won the Sister Awards for having cancer, female cancer.
And I am a 6-year survivor, so I have all my friends and my family and my kids here to support a very, very dear cause to my heart.
To me, it's the whole community for one day. Everybody is into the Women's 5K Classic. We have every hospital in the area working together today. We've got our fantastic sponsors that are all out here. It's everybody, it's just everyone does something to make this event successful.
It takes a village to get things done. And actually this whole group, 5,000 ladies, this is a village for the Lehigh Valley. We're very blessed to have such a good organization.
Since 1993, the Women's 5K Classic has raised more than $2 million for breast cancer programs right here in the Lehigh Valley and beyond. So they do a lot of good work and support a lot of different kinds of programs, whether it's programs out there to help low-income women get mammography or programs that are out there to teach younger women about breast self-exam. They've done a lot of good work with that money over the years.
Right, a lot of support for women who are facing this very scary prospect. And as you had mentioned at the outset, everyone knows someone, has family members, friends who have faced it. I know in my case, my mother had a double mastectomy, and I remember how scary that was. Wow. I was only, like 13 years old at the time.
Wow.
Yeah, so way back when, and just how frightening that was right up until recently. And now with all these new technologies and new techniques giving new hope to women, it's just great.
Yeah, and it's amazing to hear 2.8 million cancer survivors, breast cancer survivors, alive today. Both of my grandmothers are survivors themselves.
Right, and it runs in my family as well, and that's the most shocking part, that we've come so far with technology, like IORT, the 3D mammographies. It's just amazing, and it's really going to change the way people view cancer and how they deal with it in the future.
And how quickly it's changed, too. I can remember doing a story about 5 years ago about digital mammography, when that was first becoming the standard of care, and now we're talking about 3D mammography being the accepted way to go coming up in the next couple of years.
And yet some things never change. As Natalie pointed out, you still have to be your own best advocate, and you have to have what they call breast awareness, or awareness of your own body, so that you can easily detect changes that you know are different from tumors or lumps or discoloration, whatever it might be, but you're aware of your own body so that you can identify these problems really early on and get some attention for them.
And thanks to Natalie and, of course, Brittany's reporting, we learned that new word today, Previvor.
Right, exactly.
Right.
when they're actually, doing something to prevent it before surgery. They're predisposed to it and do something to prevent it. It's really phenomenal.
So thank you so much for both of your reports today and for your hard work on this. Our next Focus on Health is not going to be until January, when we actually focus on children's health. So we'll have a lot to share then, too.
Great.
Well, thank you for joining us, and remember to focus on what matters.
Support for Focus is provided by
the people of Air Products feel privileged to bring this programming to you. By supporting education and the arts, Air Products strives to improve the quality of life here in the Lehigh Valley, where we call home.
In 1948, John Walson put an antenna on top of a mountain and ran a cable back to his television store. Cable TV was born. Now, over 60 years later, his vision has changed the way we get our information, from super high-speed internet to stunning high-definition television. Service Electric is committed to leading the way in the community with the best coverage of local high school, college, and professional sports, and groundbreaking technology in this ever-changing world. Service Electric Cable TV. A vision for the future.
This week on Focus, a must-see show for parents as PBS 39 teams up with the Weller Health Education Center to spotlight domestic abuse. Reports show 1 in every 4 women will experience domestic abuse in her lifetime, but research shows the rates climb even higher among teenagers. In Pennsylvania alone last year, 141 people lost their lives to intimate partner violence. We share information to prevent this violence and resources to help right here in our region. Don't miss this special report when we focus on what matters.
PBS 39 thanks Northampton County for their support.
He's a caring man of the cloth with a special gift for solving murder cases.
I don't so much look for mysteries as they come looking for me.
The clever crime solver with divine inspiration.
I only want to uncover the truth.
Father Brown.
Coming soon on PBS 39.
Thousands of great photographs were submitted during the Capture Greater Lehigh Valley Photo Contest. Now we present the Capture Greater Lehigh Valley Photo Book, filled with hundreds of the best photos of the people, places, and panorama that make up our area. It's the perfect book to have or to give to your friends and family to enjoy. Go to WLVT.org and order your copy today. WLVT.org is your place for the Capture Greater Lehigh Valley Photo Book.
On Masterpiece Classic.
Living in a small town wasn't enough.
From the novel by Emile Zola, the story of a magical place, the mesmerizing man who owns it, and the young woman who finds herself in the paradise.
The paradise can lure every woman in this city through our door.
I need to know what Murray's up to. I need to prevent him from excess.
I must prove that the paradise can conquer this whole city.
The Paradise on Masterpiece Classic.
Wednesday at 9 on PBS 39.
I'm Steve Thompson, and for almost 50 years, PBS 39 has inspired our community to think, feel, and learn something new every day. We're proud to provide programs and services to more than 110,000 students and 11,000 teachers, including our electronic field trips, educational workshops, summer camps, and more. That's the power of public media, and we couldn't do it without your support.
On Masterpiece Classic.
Something happening in this house is actually about me. Edith is beginning her life as an old man's drudge.
So this is the moment when you receive a huge fortune that could save Downton and you give it away.
Darling, I hope you can understand.
I'm trying.
Downton Abbey on Masterpiece Classic.
Friday at 10 on PBS 39.
This special is brought to you by Capital Blue Cross.
To go forward, you have to go back to when you were braver than you knew.
Go there with the power of a card. Accepted by over 90% of doctors and specialists. Capital Blue Cross. Live fearless.
Early detection is a beautiful thing. When backed by advanced technology, skilled surgeons, a collaborative team, and a personal touch. Because you may have cancer, but you have so much more. Breast Health Services at Easton Hospital. Learn more at easton-hospital.com or 610-250-4567.
Funding for this program is provided by